Okay, and good morning and welcome to the Davies Use Case webinar being presented by East Tennessee State University on improvement of quality scores. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety. It is my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies of Excellence, Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today from East Tennessee State University, Monica Briggs. Monica, I will turn the presentation over to you.
Good morning. My name is Monica Briggs. I come to you from East Tennessee State University, Department of Family Medicine. It's a pleasure to have the opportunity to speak to you today about our Davies application and our quality scores. What I'd like to do is start by telling you a little bit about our quality improvement team that's been key to improving our scores. Again, I'm Monica Briggs. I am the Director of Informatics and Optimization for the department. I have been in this position for about 4 years now, and prior to this position with family medicine, I was the EHR administrator and in charge of rolling out our current EHR system to approximately 1,000 end users. So it's quite a challenge, but did definitely prepare me for the position I'm in today. Also, part of the quality improvement team is Julie Montgomery. She's the clinical quality data manager. She's been with the department for about 3 years, and her role, she does a lot in population health and data analysis. She does contract management and, of course, quality improvement. We also have, and she's not on the slide, but we have Vanessa Cantor. She has a bachelor's and a master's in business, and she joined our team in January, but she's been part of the Department of Family Medicine for about 18 years. She's in charge of doing a lot of reports and policy creations, and she does a lot of audits for our team. And we also have Julie Ashens. She is our clinical services coordinator, and her primary focus is on patient-centered medical home. And then lastly, we have Ethan Sams, who is our student worker, and he focuses a lot on gap closures and working reports as well. Our mission at East Tennessee State University Family Medicine is that we provide community-focused medical education and evidence-based patient-centered care to improve the health in rural southern Appalachia, especially among the underserved population, to model compassionate and efficient care using effective communication skills and to advance scholarly investigation. We lead through excellence, collaboration, and innovation. And this is important to know because we are in a rural area, and our populations is very, very hard to manage. So East Tennessee State University Family Medicine is located in the northeast part of Tennessee. We have 3 different locations, one in Bristol, Johnson City, and Kingsport. We are located in 2 different counties, Washington and Sullivan, and if you look at the map, we are very close to North Carolina and Virginia. So we have a very diverse population, and it's very rural as well. And just some facts about our department. Our clinics opened in 1976. In 1978, we did have our first class enrolled as medical students at the medical school. Then we jumped ahead quite a bit. In 2007, we were named the best rural program in the nation by the National Rural Health Association. In 2010, we formed our Health Information Technology Committee, and this was formed mainly to decide on the platform that we would use for our electronic health records. And then in 2011, we received our first NCQA Level 1 PCMH recognition. And it's important to note here that this is while we were still on paper, and it was on the 2008 standards. And then in 2004, we received Level 3 PCMH recognition, and at this point we were on the EHR, and this was on the 2011 standards. In 2015, we joined an ACO, and it's a Track 1 MSSP. We had actually joined an ACO in 2014, but it was rather difficult for us to manage and get some information. So we really became active in 2015 with the current ACO that we're in today. Also in 2015, we developed our chronic care management team. And then in 2017, we recertified and gained the Level 3 PCMH recognition, and this was on the 2014 standards. Next year, we do go to our yearly submissions for NCQA. And then also in 2017, that is when our clinical quality improvement team formed, who I briefly told you about previously. And then as we stand today, we currently have 13 managed care contracts that we are keeping up with. Some important things that I didn't add to the slide: we do participate in Comprehensive Primary Care Plus, or CPC Plus program. We did have the application process for all 3 of our centers, and each of them were approved. I believe we are 1 out of 56 in the state of Tennessee that were approved to participate in the program. And our patient population mix, we are 80% Medicare and or Medicaid. So being in a rural setting and with a population 80% Medicaid or Medicare, it's a very challenging population. So our team members, I'm going to tell you a little bit about our clinic structure and what it looks like. So each clinic, we have anywhere between 11 to 13 faculty physicians, and the faculty physicians are managed by a medical director and a program director at each site as well. We have anywhere between 18 to 22 resident physicians. We also have 1 nurse practitioner at each site. We have a social worker, a pharmacist, and a psychologist as well. We have our breakdown in team members from nurses to front desk. We have anywhere between 56 to 60 at each location. And then we have an administrative team that includes our physician chair, our physician vice chair. We have an executive director, the operations manager, a business manager, the quality team, and we also have a very large research division. So we have approximately 185 employees for all 3 of our family medicine locations. Something important here to talk about is we do take an interprofessional approach to our teams. As you can tell, having a diverse group of people, social workers, pharmacists, psychologists, behavioral health on our team, we are very fortunate to have that model, and we feel that it really benefits and helps us with our quality, and really did help quite a bit with our quality scores. And because of the interprofessional work that we do here at ETSU, we have been nationally and globally recognized for our interprofessional work. And we're going to talk a little bit more about interprofessional a little bit later in the presentation. So now we're going to go right into the case study and what we did to improve our quality scores. So the local problem, in 2014, I briefly mentioned that we did join an accountable care organization, but we really became active in 2015, and we began looking at our quality measures and how we were capturing quality measures. And we were thinking that we were doing a pretty good job in capturing the data, however, we were not seeing much improvement. So by the end of 2016, 2017, after really using health IT, creating better workflows, processes, doing a lot of report integrity checks, creating our own databases, we were definitely able to see a significant move in the right direction. We found that we were missing a lot of opportunities when the patient was being seen in the clinic, when it was related to quality and preventative health. So I'm guilty for this. I only go to the physician when I'm sick. I very rarely go just for preventative health. And we were missing those opportunities for those patients that only come in when they're sick. So we realized that that was a problem that we needed to address. Our clinics also needed a more efficient way to capture patient information as it related to preventative health. We didn't really have a mechanism in place on, capturing who else the patient was seeing, and who they were following, who do they go to their eye doctor for, do they have regular eye appointments, and that sort of thing. So we identified that that was a problem as well. We also found that all of a sudden in 2015, not only were we involved in an ACO that was very demanding and wanted to see improvement in our scores, but all of a sudden it seemed like overnight we were suddenly tasked with taking care of all of these managed care organization quality measures as well. And we didn't have a good way to really identify and find what our focus needed to be on. So that was what we considered a problem as well, and we really needed to kind of find what our low-hanging fruit was, what was our focus going to be. And then lastly, a problem that we identified was reports that we were receiving from the MCOs have significant lag time because it goes off claims mostly. And it was very hard to manage what we needed to do with such old data. So we needed to figure out a way that we could really manage this real time to really see significant movement. So next we're going to talk about the steps that we took to improve our quality scores. And specifically we're going to talk about the design and implementation and how we used health informatics or health IT, and then the value that we received from it. So what we're looking at here is in the very center you see the word create. We found that we really had to create a lot if we were going to see any movement in our quality scores. And as we kind of move outward from the word create in the center in this diagram, we needed to create workflows. We needed to create dashboards, new processes. We needed to create something that would identify a smarter measure, and we'll talk about what it means to have a smarter measure in just a moment. And then, how are we going to use some of the things that we were creating and making, how are we going to implement that? So some of the stuff we implemented into huddles, or we had to create huddles. We had to create quality assessment forms. We did pre-visit planning. We had to create new flow sheets and clinical quality measure forms. And we're going to talk about all of this, but really this diagram shows, we had to create a lot to make all of this work. And champion teams. We talked earlier about interprofessional teams. And being a teaching facility, it's very important that we get the buy-in from everyone. And the approach that we take is we deploy what we call champion teams. And we define champion teams as a way for our programs to implement a strategy for quality improvement. So quality improvement is often taught as a collection of tools like the Plan, Do, Study, Act, or PDSA cycle, or database decision-making, etc. But they are not held together by a process for how to do it. And champion teams is, kind of how they're held together and how we approach creating something new. And champion teams, they have the power to impact the success of a program. They are accountable for the project's success, and it provides leadership to the project in our organization. So champion teams are key to anything that we roll out new in our organization. We always deploy a champion team before we start something. And we're going to talk a little bit more about that. So in this particular process in improving our quality scores, the champion team basically consisted of physicians, residents, nurses, front desk, and they were in charge of basically developing, providing feedback for what we were building or creating. They, helped with the whole entire planning process. So they were, like I said, key to the development and implementation of improving our quality scores. And specifically, what this champion team was responsible for was determining what the purpose and the goal was of this project. They were responsible to provide background, so why is this important? And, they were in charge of creating a process and environment for success and promoting and supporting that implementation. And then after that implementation is put into effect, gathering data and seeing if it was a success or a failure, and reevaluating it at the end. And is this something that we want to push out to everyone? Because with any champion team, we start small and incorporate something into a smaller group, and then if it was a success, then we push it out globally. But if it failed, or if we need to make tweaks, we change that process. The champion team's in charge of changing that process, trying it again, and then reevaluating it again. So we talked about the PDSA cycle. So our champion team, we do follow this with any project that we're doing. So we try to figure out, what are we trying to accomplish? What are our aims? What measures, are we going to try to meet? How will we know that a change is important? and what changes can we make that will result in improvement, and testing those changes, implementing those changes, spreading those changes to others when we're ready to push that out globally. So we have our champion teams, and then they follow the PDSA cycle. So when we specifically look at the design of our champion team for this particular project for improving our quality scores, the plan of the PDSA cycle was this champion team did meet every month, and then as it got closer to a rollout time, it went to more frequent meetings of every 2 weeks. In the do part, they, we started with one site, and we would do that testing at the one site. We call it our pilot site. And then in the study is after that pilot is over, they would, we'd reconvene and gather the data, the statistics. Did we improve our scores? What worked? What didn't work? And the act part, do we go live? Do we tweak and then go live? And then we also, after we do act and go live globally, we do ongoing audits to ensure that what we put in place is still being done today, that we're still seeing improvement, and it's just to ensure that we are compliant with what change and what policy and process we put in place. So the accomplishments that this team wanted to improve or wanted to see happen was we definitely wanted to see better communication. So that was better communication between our interprofessional teams, between front to back, from nurses to physicians, just better communication all the way around. Of course, we wanted to see improved outcomes. That was one of the accomplishments, one of the goals of the champion team. We also wanted to improve patient engagement. How do we get the patient involved in this process? Because we did see with the rollout of EHR, some of the physicians were concerned about losing some of that patient engagement, and we wanted to ensure that this process we could encourage patient engagement and provider and staff engagement as well. And then our interprofessional integrated teams, how could this process, improving our quality scores, how could we do more warm handoffs to our integrated interprofessional team? So this was what we wanted to accomplish by the end of our quality score improvement. And now we're going to look at how the health IT was utilized in this entire process. And this is just like a graph of basically like what we did step by step. We're going to go into all of this in more depth, and you'll see how it builds upon one another. But the first thing that we did was the clinical quality measure forms. So we had to come up with a, what we call a gap sheet. Like I said, we're going to talk about more, and you're going to be able to see what this looks like here in just a moment. But basically, the gap sheet is something that we designed internally, and our staff will pull it off of our database, and then they use this. The next step is at our pre-visit planning. So they use our gap sheet, our clinical quality measure form, in the pre-visit planning piece. And the pre-visit planning staff basically looks and sees what gaps there are, what can they go ahead and order inside of the system using standing orders. And then they go to, after pre-visit planning, they go to huddles. So we've got the clinical quality measure sheet rolls directly into our pre-visit planning, which then rolls directly into our huddles. And this is designed to have the clinical staff we have morning and afternoon huddles. They come to the huddles, and they're not running down every single person that's on the schedule. They are just giving brief overview, saying, I have, 8 patients this morning. I was able to go ahead and order this, this, and this. I've called on records from the ophthalmologist. Dr. X, you'll still need to speak to the patient about their influenza vaccine. And then all of this, up to this point, the clinical quality measure forms, the pre-visit planning, and the huddles is happening before the patient even arrives. The next step, the quality assessment form, is when the patient actually gets here. And this is part of the patient engagement that we wanted to see. So we give the patient a clinical assessment or quality assessment form for them to fill out. And then when they fill that out, that gets loaded into our flow sheet, or what we call our dashboard. So now that you kind of see an overview of kind of how we used Health IT, now we're going to go into each step and what that looks like and what we developed. So we talked briefly about it was very hard for us to, it seemed like overnight, we were involved in an ACO and 13 managed care contracts, and we were trying to keep track of like 80-some measures between all these programs. We needed a better way to gauge that. So what we did was developed what we call a smarter measure crosswalk. And this is just a snapshot of what it looks like when we, across the top, have all of the programs that we participate in. And down the left-hand side is the description of all of the gaps that we have. Then we went in and we compared what each program was asking for. And many of you know, all the programs ask for different things. A1C is a perfect example. You might have Blue Cross Blue Shield program that wants to see A1Cs that are under 9, and then you'll have another program that wants to see them under 8.5, and another program that it's under 8. So what we did is we compared those, and we go by what we call the smarter measure. So with the A1C, our goal is to keep our A1Cs under 8, because that's the hardest measure to meet. And being a teaching facility, this was very important because we always have people rotating through our clinics, and it's very hard to train physicians that, okay, for this program, Blue Cross and Blue Shield wants this patient to be under a 9, but now United Healthcare wants it under 8. We didn't train it that way. We just went out to the clinics and said, our goal is to keep our A1Cs under 8. And this tool was a very, very important piece for us, especially on the administrative side or the quality team, to kind of know what our focus needed to be on and how we needed to train our physicians and staff. This also shows, you're seeing some X's and 2 X's. This signifies to us, if we see 2 X's, that we have an electronic feed with that group. So this was a way for us to quickly go and say, oh, we have a feed that goes directly to Blue Cross Blue Shield, but this particular program is just claims-based, or that sort of thing. We also, on the back end, we have exclusions built in that will let us know, although you're not seeing them here, every program has different exclusions, and we have all that built in on the back end in our databases. So what you're seeing here is what I call our gap sheet, but it's our clinical quality measure sheet. And this is for one particular provider, and this is a homegrown thing that we built ourselves because, again, it was hard to rely on the payer data because of the lag time. So we needed to build something that would let us know as close to real time as possible what gaps were out there. And we chose to focus on, you're seeing across the top the gaps that we chose to focus on. And what happens is each week the clinical staff goes out to our database that houses this, and they pull these off. And each physician that's in the clinic that week will get one of these, and the nurse will review it and say, for this first patient, there's a star in the diabetic A1C. So that's telling us that we need to order an A1C. And another patient may need a mammogram. And the nurse will use this sheet, and using standing orders that we have set up, will go into the system and go ahead and order a lot of this stuff before the patient even arrives. And then this sheet will then go to the physician, and it'll be highlighted on what the physician still needs to address. So this has been a good communication tool between the physician and the nurse, and it has been very successful in helping us know at any given visit, sick or annual wellness visits, health maintenance visits, at any visit we know every gap that the patient has. We recently, last year, also added if there were any HCC diagnosis codes that still needed to be assessed when the patient arrived, and that's very important for our risk scores. So it was a very important piece that we added last year to our gap sheets. So then from here, the nurse will then take the gap sheet and do the pre-visit planning. And we kind of already spoke about this, but the nurse, they'll print this off or the gap sheet off, and then using standing orders, they'll place orders as necessary. And it may be that it says that the patient was needing an eye exam, but it's just that we haven't received the records from the ophthalmologist. So also in the pre-visit planning, the nurse will go and pull records if necessary, or have our referral clerk call the ophthalmologist and get records sent. And then the nurse then reports out in our huddle the findings. So she will take the gap sheets and review these in our daily huddles. And like I said, our daily huddles, we do one in the morning before clinic starts and one in the afternoon. And, huddles are very brief. We try to keep them between 5 to 8 minutes. So it's really just a very brief report out. It's not talking about every single patient that's coming in, but they just do a brief report out. Says, Dr. X, she's got 8 patients. The only thing that you need to worry about is on, patient that's coming in at 8:30. You need to talk to her about the influenza because in the past she's declined it. So the huddles was also a great opportunity for communication and staff engagement with each other, and it was very successful. This right here is kind of what we use for standing orders. So over on the left-hand side, you're seeing a screenshot of what we call our order groups. And we build these, if the patient has a gap identified that they need a colorectal cancer screening, the nurse can go into the order group and they can click on that folder, and it will drop down, what her options are, what his or her options are, and then just order it from here. So these are very useful because there's not a lot of searching in our EHR system. We have these order groups that we built that they just go and click on it and, click a button or click the folder, and it orders everything inside of that folder. On the right side, you're looking at our clinical decision support tool. So even though we have built the gap sheet and the nurses are putting in the standing orders and using these order groups, the clinical decision support tool is turned on. So then if anything else is missed, it always flashes up for the physician. So there's always one last look to see what gaps are we missing, what do we still need to do. And so for this patient, for instance, we missed the mammogram. So maybe the nurse was busy and wasn't able to order it, but it says that we still need it. It's overdue. The good thing about this tool, not only does it serve as a reminder of still what needs to be done, but right from here, the physician can right-click on that mammogram and order it from right within the screen. So there's no backing out, going in, click in, ordering, and that sort of thing. It can be done right from here. And then everything that we talked about up to this point has been done before the patient even arrived. So now this is showing what the patient sees. So over on the left-hand side is our quality measures assessment form. And this is really kind of just some preventative type questions that we have the patient fill out the first visit of the year. The first visit they come in, they get this sheet. Yes, it is in paper form, but we are in the process of hopefully getting them moved over to iPads. And they would just fill it out on iPads, then it would go into our EHR system. But we haven't got there yet, but it is in the works. So right now, it is paper. As the patient is waiting in the waiting room, they fill this out. And then when they get called back, the nurse then loads it into our quality assessment form flow sheet, which is what you're seeing on the right-hand side. And the flow sheet, anything we put into a flow sheet is discrete data, and it's important for us to put it in that way so we can pull information out. So this process was very helpful because a lot of things were being identified that we didn't necessarily know. Like, for instance, we would ask the patient, did they have a DEXA scan? And they did have a DEXA scan, and we didn't necessarily know it because we didn't order it, or maybe they see an OBGYN and we did not know that, and when their last pap smear was. And so this clued us in on who we needed to outreach to, where we needed to go get records and whatnot, and this really helped our process in getting good data into our EHR system. And so when the nurse enters the quality measure form into the flow sheet, it's built to go into our note as well, and it's in Keynotes. So what we're seeing on the left-hand side is in our annual wellness visit note. So the physician can see what the patient answered in there. And then on the right-hand side, this is the output. So if we were to print this off or send this to a referring physician or someone else, this is what the output would look like from the flow sheet that was built. And then this is a very busy report, but it was very, very useful in our success for improving our quality scores. And this is our ACO dashboard or report that we have. And of course, green is good, red is bad, yellow, we're right in the center, we need to improve a little bit. But this goes out on a monthly and then towards the end of the year, a weekly basis, and it tells us where we're at on certain measures. And we're able to hone in immediately to the red areas and see what we need to improve on. So, excuse me. And this is a great communication tool for the physicians. So when I send this out, I immediately will get responses back from physicians and nurses saying, well, why are we in the red for this? And it's, I can tell them, give them their numerator and denominator, and tell them exactly what we need to work on. And this also gets posted. We have what we call an information station board inside of the clinic that has a lot of reports and shows where we're at. And this has just been a very, very useful tool, and we can hone in on our low-hanging fruit, so to speak. So this has been very useful. Okay, so the next thing that we're going to talk about is the value that we were able to see from improving our quality scores and incorporating health IT. I'm going to show a lot of graphs, and we're going to kind of talk about those graphs because I'm a visual person, so it makes sense to see it visually. But we were able to see improved health outcomes for our patients. We were able to decrease our risk scores by 1% each quarter over a 12-month period. And this is actually very astonishing once you see our patient population and where they fall in terms of risk compared to the state of Tennessee. So this was quite an accomplishment, and we really look at the processes that we put in place to improve our quality scores significantly or correlated very closely with why we saw a decrease in our risk scores. We also saw a correlation with decreasing our hospital admissions and our emergency department utilization. And we also, because of streamlining our quality measure, in our scores and putting better processes and using health IT, we did receive financial bonus of $1 million in 1 year. So very significant value that we got from this entire process. So what we're looking at here is our risk tier level 4s. These are our highest level patients, so our sickest patients. And the orange shows the percentages for the state of Tennessee in risk level 4s, and the blue is where we fall as a department. So when you just look at how we compare to the state, we are significantly higher for sick patients. And what this shows is in Q1 of 2017, 32% of our population was a risk level 4 compared to 21% in the state. But by Q1 of 2018, we have dropped it down to 29%. So we saw a 1% decrease every quarter in the year of 2017, and we continue in 2018 to at least stay flat, not going up or going down. Of course, we want to see that number go down, but this was significant for us. This was very visual. It really showed that the work that we were doing, we were seeing not only benefits for our department, but benefits for our patient, and that's really where our focus wanted to be, was for our patients. This is, I pulled some data to see where we started at with our colorectal cancer and our mammogram screenings. And in 2015, you can see in the blue where we started at, and then the gray is where we were at the end of 2017. So for colon cancer screenings, we saw a significant jump. And then for mammograms, what's important to note here is that 2016 and 2017 pretty much stayed the same. But between 2015 and 2016, we were able to put a electronic feed in place from our local hospital system, where the majority of our patients go to get their mammograms. And so when they go, now we get that electronic feed directly back into our EHR system as discrete data. So that's why we kind of stay stagnant between 2016 and 2017, where in the colon cancer screenings, we continue to improve. Unfortunately, we don't have any electronic feeds for those types of reports coming back. But we looked at this graph and was really astonished to the improvement that we were able to see. We also were able to see significant improvement in our pneumonia vaccines. So when we started in 2015, we were at 47.37% of our patient populations that were 65 and older received the pneumovax. By 2016, we had got that up to 84%, which is a significant improvement. And by the end of 2017, going into 2018, we were at 86%. So we continue to improve, but it's just amazing to see this visually on how much we were able to improve. Tobacco screenings, we also saw a significant jump. So in 2015, we were at 54.41% of our patients received a tobacco screening. And if they were positive, then we had to do something about that, providing smoking cessation or something. And so from 2015 to 2016, a significant jump. We went to 93%. And then in 2017, we remained the same at 93%. So again, another significant improvement, and it's not just an improvement for us, but it's improving the health for our patients as well. And the influenza, we also saw a big increase. So in 2015, we started at 60% of our patient population received the influenza vaccine. And by 2016, it was 89.41%, and then in 2017 was 90%. And I will say that, that doesn't necessarily mean that we were giving all those injections, but we had better systems in place where we would outreach. We were not getting a lot of the information put into our EHR system when the patient would go to their pharmacy to get their injections. And now we have a mechanism in place where we can identify where the patient's going and actually go out and get that information and load it in our EHR system. And then the last slide that we're going to go over, I think just really sums it all up. And this shows that what we put into place, we saw improvements across other areas in our department. So when we look at total expenditure, and this is for our Medicare population, so in 2017, quarter one, excuse me, we started low and we kind of went back up, but then we're seeing that curve back down. Now, granted, we are a lot higher than our region, but we are going in the right direction, and it directly correlates to the mechanisms that we put in place for a quality improvement. And then the bottom slide shows, we were able to decrease our inpatient hospital utilization. So, we correlate that by improving our vaccines for influenza, pneumonia, making sure that the patient's getting their preventative checks. We're bringing down healthcare costs, and we're also keeping the patients out of the hospital. So truly, it's been a win-win for our department, our region, and for our patients. And if anyone has any questions, I thank you. You can feel free to email me, and thank you for the opportunity.
Well, thank you, Monica. That was a great presentation. I want to also remind folks where to go find other this recording and other Davies use case webinars. That information can be found at the HIMSS Davies website at hims.org/Davies. Again, that's him.org/Davies. Have any questions? Here's our contact information. Feel free to reach out to us. Thanks once again. And,